So today I'd like to present a little bit about spina bifida care. It's particularly important to me because Ireland actually has one of the highest incidences of spina bifida in the world, with an incidence of about 1 in 1,000 patients. The provision of care in Ireland, while available, is quite uncoordinated, and it's something that I hope to improve upon when I return back to Ireland next summer. So spina bifida, it's a neural tube defect where there's incomplete closure of the spine and the membranes around the spinal cord. And it comes from the Latin meaning split spine because of its appearance on X-ray. There are 4 main subtypes. The first is spina bifida occulta, where the vertebral arches don't close fully in the back, but there isn't any protrusion of material through the defect. In a meningocele, there's a protrusion of the meninges. Myelomeningocele means there's a protrusion of the spinal cord and meninges. And then the 4th subtype is lipomyelomeningocele, where there's a lipoma protruding through the defect that connects the spinal cord to the skin. There's an incidence of about 4,000 patients with spina bifida in BC, with an incidence of about 2.25 cases per 10,000 births prior to the state-mandated introduction of folate fortification in 1998, and the current incidence is around 0.8 cases per 10,000 births. There's a lot of research looking at candidate genes and environmental factors which cause spina bifida. Certainly, DNA methylation is important in terms of epigenetics, and this is why we recommend folate supplementation in women trying to conceive. There's a 4% risk if a sibling or a parent is affected with spina bifida. Hispanic people appear to be disproportionately affected, possibly due to polymorphisms in the MTHFR gene. Females are more commonly affected, and they suspect that that's due to something to do with the P45 pathway. In terms of environmental factors, obviously folic acid deficiency, medications such as methotrexate and antiepileptics, obesity, diabetes, and alcohol misuse. The diagnosis nowadays is usually made antenatally due to an increased alpha-fetoprotein in the maternal blood, or due to the appearances on ultrasound as shown in the right, or again an increased alpha-fetoprotein on amniocentesis. Some diagnosis may be just made at postnatally, particularly if the mother hasn't had antenatal care. And in the case of spina bifida occulta, there may be some cutaneous signs, such as a pitting, a lipoma, port wine stain, hemangioma, a tuft of hair known as a fawn's tail or human tail. The traditional management was postnatal closure of the defect within the first few days of life, but now they're moving towards prenatal management and fetal surgery, and that can be an open repair via hysterotomy or fetoscopic surgery. The management of myelomeningocele study, or MOMS study, was a randomized controlled trial to compare the safety and efficacy of prenatal versus postnatal repair of myelomeningocele. And they included all singleton pregnancies with a gestational age of less than 26 weeks and a normal karyotype. All patients had a myelomeningocele and evidence of hindbrain herniation. And the MOMS-1 study reported on 12-month outcomes from 158 patients that were randomized over a 7-year period. In terms of maternal outcomes, there were no maternal deaths. The prenatal surgery group did have an increased risk of pregnancy complications and an increased risk of spontaneous labour. 1/3 of women had a dehiscence or a thin scar at the site of the hysterotomy at the time of delivery. And in terms of neonatal outcomes, there was 2 perinatal deaths in each group and a similar rate of adverse outcomes. However, the prenatal surgery group were delivered earlier at a median of 34 weeks, and 13% of those babies were delivered at less than 30 weeks. 1/5 had respiratory distress, and that was most likely related to the increased prematurity in this group. So although there was an increased risk in terms of maternal and fetal outcomes, the functional outcomes appear to be better in the prenatal group, with a reduced need for VP shunting and a reduced incidence of hindbrain herniation. So remember, all these babies had evidence of hindbrain herniation at enrollment, but 36% of babies in the prenatal group had no evidence of herniation on delivery. These patients were more likely to have a level of function greater than 2 levels better than expected, and less likely to have a level of function greater than 2 levels worse than expected. And they were also more likely to be able to walk without orthotics or devices, so 42% versus 21% in the postnatal group. So what happened to these mothers if they became pregnant again after open fetal surgery? Well, there was a very high risk of uterine rupture, between 9 and 14%, and this led to Texas Children's Hospital to perform an experimental fetoscopic closure of a neural tube defect in 2014. This procedure is now available in 11 centres in the world only, and a recent systematic review found that there was an increased risk of preterm rupture of membranes with fetoscopic surgery versus open prenatal repair, and an increased need for additional treatments of the repair site on delivery. There was, however, a substantial decrease in the risk of uterine dehiscence. There was no difference in overall outcomes in terms of VP shunt or hindbrain herniation, and no difference in the rates of placental abruption. On delivery, or postnatally, the main goal of care is to preserve renal function, and to do that by ensuring a low pressure reservoir to reduce the risk of upper tract dysfunction, and also to reduce the risk of UTIs. As the child progresses towards a school going age, we focus on achieving bowel and bladder continence. In terms of achieving a bladder regime, that can be achieved through a combination of anticholinergics, Botox, intermittent catheterization, and in some cases bladder augmentation with or without a catheterizable channel. In terms of bowel regime, options include glycerine suppositories, digital stimulation, oral laxatives, a peristeen or a MACE procedure, which allows for antegrade enemas. Then as the child progresses towards adulthood, we focus on counselling surrounding independence and sexuality. The EAU and ESPU have produced some guidelines where they recommend 2 treatment strategies. One would be proactive treatment, where you introduce intermittent catheterization with or without anticholinergics early in the first months of life. But the approach that we have here in BC Children's is a more reactive management protocol, where we only start these interventions if problems or changes occur. We follow a standardized surveillance program where renal ultrasound and creatinine are performed within the first week of life. The ultrasound creatinine are repeated at around 3 months with video urodynamics. And then at regular intervals, we will perform creatinine and renal ultrasound. Urodynamics should be repeated every 2 years unless there is some clinical change. Parents of these children, when we see them in clinic, will often have a lot of questions. Will the child be able to walk normally? How will their bladder and bowel function be? And then perhaps some private thoughts. How will this child engage with school? Will they have a job? Will they have relationships? And sometimes you can feel like this guy in the middle with the crystal ball trying to predict the future. Thankfully, in the US, there's a national Spina Bifida patient registry, which was sponsored by the CDC, and 26 centres throughout the US contribute to the registry. This has led to a number of valuable publications which can help inform our counselling for these patients. In terms of answering the question, will my child be able to walk? This publication had 2,600 patients over the age of 5, and 46% of those with myelomeningocele, shown in the plot on the left, were able to ambulate in the community. For those with non-myelomeningoceles, 92% were able to ambulate in the community. Those with myelomeningocele, a higher level of lesion or VP shunt, were less likely to be ambulatory in the community. In terms of continence appeared to improve with age. Those with non-myelomeningocele were over twice as likely to achieve bladder continence, and the level of spinal lesion was also important. 20% had a bladder reconstruction, and just to give some local data here, we've performed 94% lower urinary tract procedures on patients with myelomeningocele over the last 20 years. The patients undergoing surgery in the National Spina Bifida Registry were older, more likely to be female, more likely to be non-ambulatory, more likely to have a higher lesion, and more likely to have a myelomeningocele. There was also substantial variation in rate between centres, and I suppose this speaks to the lack of standardisation in terms of how we're managing bladder continence. In terms of bowel continence, 58% of patients on the registry had bowel continence overall, with 55% in those with myelomeningocele and 75% in those with non-myelomeningocele. 20% managed their bowels with an antegrade enema, and for those unfamiliar with these procedures, on the top picture, this is a MACE procedure where the appendix is used as a channel to connect the cecum to the skin, and the bottom picture is a cecostomy tube, which is a silicone insert that needs to be replaced every 3 months. Transitional care is very important, and I know Thomas would have spoken about this in Grand Rounds 2 years ago. It occurs at a vulnerable time in the patient's life. They're discovering their sexuality, seeking independence, and managing kids is relatively easy in that regard, in that they're generally cute and they've got good support structures. But as they transition to adulthood, the social structures change, and they share the similar hopes and desires of able-bodied people and seek similar experiences. And they participate in risky behaviours just like anyone else, and that can expose them to complications. Transitional care, formalised transitional care is important, and we know that patients who transition successfully are less likely to require unscheduled care. Patients with spina bifida can develop specific urology complications, including bladder stones, kidney stones, UTIs, and augment rupture, in addition to stomal or channel complications. Again, Thomas would have spoken about the management of these 2 years ago, so I'm not going to dwell much on them further, just to say that patients with spina bifida are a special high-risk group, and their perioperative care is very important. They're more likely to suffer from obesity, kyphoscoliosis, hip dislocation, contractures, osteoarthritis, and up to 40% will have a latex allergy. In terms of perioperative care, as a staff, I think it's important to manage the positioning of the patient perioperatively and perhaps not leave it to the resident. The arm function of patients with spina bifida is very important, so it's important that the arms are placed in a neutral position to avoid any neuropraxia post-operatively. The spine in the lower body should again be in a neutral position and supported with gel pads, rolls, heel boots, or fillers. It's important to keep the dependent skin dry to minimize the risk of skin ulcers, and also to promote early return to preoperative health. One study of laparotomies performed for urological reasons showed that 40% of patients developed an ileus postoperatively, 20% developed pressure sores, and 40% developed clavio-dindo complications of 3 or above. In terms of the surgical management of renal calculi, patients with spina bifida are twice as likely to develop UTIs, acute kidney injury or respiratory complications. I'd like to finish just by discussing a couple of cases which outline the psychosocial aspects of spina bifida care, which often perhaps don't get the attention that they deserve. So our first case is Jane. She's a 23-year-old woman. You see her annually in your stone clinic following a successful PCNL in 2016. She's no residual stone burden, thankfully, but she's recently met a cute guy at work, and she's got a couple of questions that she's hoping you can answer. She has a background of a lumbar myelomeningocele. She's ambulatory, and she manages her bowels with a glycerine suppository, and she voids by Crede. She hasn't had sex yet, and she's a little apprehensive, and she's wondering, is there anything that she should know? Can people with spina bifida have an orgasm? She's worried that she might have some bowel or bladder incontinence during intercourse, and she's looking for a few tips on how to prevent this. And nobody's ever really spoken to her about fertility, and she wants to know, is she fertile, and how careful does she need to be? It's very easy to forget that spina bifida people do engage in intercourse and have the same kind of sexual desires as able-bodied people. This is a study by Sawyer of Australian adolescents up to the age of 23, and it's interesting that 60% of people in that group have had a boyfriend or girlfriend in the past, and 90% wanted to get married, and 76% wanted to have children. In fact, 2 women were already married and 1 was engaged, and 1 young woman already had a child. 80% of the women in the group had some kind of genital sensation, and almost 40% had a previous orgasm. 25% had sexual intercourse. This is an internet-based survey that was distributed online by spina bifida advocacy groups, and 60% of the respondents were sexually active, but only 44% stated that a physician had discussed contraception with them. So in terms of contraception, these women will have the same options for birth control as the general population, but that does come with a number of caveats. There is a potential for latex allergies, so non-latex condoms are preferable. In terms of the oral contraceptive pill, you have to consider the risk of thrombotic events in patients with deficient mobility. Progesterone-only pills may increase the risk of osteoporosis, which patients with spina bifida are already at risk of. And in terms of intrauterine devices, they may be unsafe in patients at risk of pelvic infections, particularly those with reduced genital sensation. Communication with their partner is key. Often they can have a conflict between spontaneity and self-care, but neglecting to adequately prepare for sex increases the risk of incontinence, urinary tract infections, STIs, unintended pregnancies, and pain from improper positioning. In terms of positioning, it's a little bit of trial and error, and through honesty and open discussion with your partner, they can enhance the experience and promote a healthy and trusting relationship. Orgasm is possible, as we've already discussed. Sometimes physical restrictions can limit the chances of orgasm, and also in terms of vaginal lubrication, sexual arousal may not always induce vaginal lubrication, so it's important for these patients to have a lubricant available. In terms of urinary and fecal incontinence during sex, this is often a preoccupation of patients with spina bifida. We would advise these patients to empty their bladder with catheterization before intercourse, empty their bowels with an enema or suppository in preparation. A lot of these patients will use mattress protectors or have wipes next to the bed in case of any accidents. We would advise that after intercourse, the woman would again empty her bladder to decrease the risk of UTI. And if there is significant persistent urinary leakage during sex or frequent urinary tract infections, it does raise a red flag for urinary retention, so this should be investigated. Obviously, your advice for Jane was quite effective, because a couple of weeks later, John comes to clinic and he also has a couple of questions for you. He's a 32-year-old man and he's stone-free on review, thankfully, but he was recently engaged and he's wondering about his future fertility options. He has a background of a lumbar non-myelomeningocele. He's a wheelchair user. He self-catheterizes and uses Peristeen once a week, and he describes his erections as useful. Just to recap on the erection and ejaculation physiology, these patients can achieve erections through two main pathways: a psychogenic pathway through decrease in the baseline descending inhibition from the sympathetic nervous system in response to visual, olfactory, auditory, or imaginative stimulation. And then there's the reflex pathway mediated through S2 to S4 parasympathetic nervous system in response to touch or genital stimulation. And then ejaculation, of course, is a somatic pathway mediated via the pudendal nerve. In terms of sexual function in men with spina bifida, this is the publication again by Sawyer, which showed that 88% had some genital sensation, 88% could achieve an erection, and 67% were able to ejaculate. 13% had a background of previous sexual intercourse. Although there is no accurate figure in terms of infertility in this population, we do know that patients with spina bifida have spermatogenic defects, and they can have infertility issues due to failure of sperm transport, either through erectile dysfunction or ejaculatory dysfunction. In terms of spermatogenic defects, Hulting examined the semen of 9 men with spina bifida and found that 4 were azoospermic and 4 were oligospermic, and this wasn't associated with the level of lesion. And then Riley and Oates examined the semen of 10 spina bifida males with erectile dysfunction, and all of them were azoospermic, and testicular biopsies revealed steroli saloni histology. The rate of cryptorchidism is higher in these patients, between 15 and 58%, depending on which study you read. We suspect that they have an altered testicular development due to deficient testicular innervation, and it's interesting that men with spina bifida will have poorer sperm motility and morphology than men with spinal cord injuries. Between 12 and 75% will have erectile dysfunction. Decter interviewed 57 men with spina bifida, and 72% had erections, and 35% had successfully engaged in sexual intercourse. The presence of a VP shunt was significantly associated with erectile dysfunction. And then Diamond interviewed 52 men with spina bifida, and 36% of men with lesions below T10 had erectile dysfunction, and 86% of men with lesions above T10 had erectile dysfunction. Many men with spina bifida will suffer from ejaculatory dysfunction. It affects about 25% of men. A VP shunt was associated with more ejaculatory dysfunction, and 70% of men with a VP shunt had anejaculation. 83% of men without a VP shunt had reported a normal ejaculatory function. For those with ejaculatory dysfunction, there's a number of treatment options: penile vibratory system, rectal probe with electroejaculation, which is performed under general anesthetic. They can have surgical retrieval from the vas deferens, epididymis, or testicles for use in assisted reproductive techniques. A Tomax procedure involves a nerve transfer from the ilioinguinal nerve, and sperm can also be retrieved from the bladder in cases of retrograde ejaculation, but it's important that the urine is alkalinized in advance of this. So in her final case, Jane attends clinic again today. She has no stones on imaging, but she's now married a year, and her husband are thinking of starting a family. And she's a few more questions for you. She wants to know what are the chances that her child will have spina bifida, and what can she do to reduce this risk? How risky is pregnancy in someone like her with spina bifida, and would she need a C-section? How will pregnancy affect her bowel and bladder function? And she can accept some worsening of bowel and bladder function during the pregnancy, but what are the chances that this will persist after she has her baby? Thankfully, there's a number of studies in these areas which can inform your advice to her. Firstly, pregnancy is possible in almost all women with spina bifida, so appropriate contraception is strongly recommended if pregnancy isn't desired. Women like Jane who want to conceive, or women who have had a previous child or sibling with spina bifida or have had an affected pregnancy should take 4 milligrams of folic acid 3 months before and in the first 3 months of pregnancy. So this is 10 times the normal recommended dose. The likelihood of having a baby with spina bifida is about 4 or 5%, or 15% if both patients have spina bifida. The rate of deliveries among women with spina bifida in the US is increasing. The mode of delivery, so C-section is more common mode of delivery in women with spina bifida, particularly in patients with hydrocephalus. C-section will be performed in about 64% of cases versus 40% of those with spina bifida occulta. This study was published in the most recent Journal of Urology in December. It's a national multi-center retrospective study from 16 centers in France. And the aim of the study was to assess morbidity and functional outcomes of pregnancy in women with a history of lower urinary tract reconstruction for neurogenic bladder. 68% of women had 96 deliveries between 1998 and 2019, and 33% of these patients had a background of spina bifida. A third had pyelonephritis during their pregnancy, and 13% had an episode of acute renal colic. 14% required urinary diversion during pregnancy in terms of urethral stenting or nephrostomy. 13% noted de novo urinary incontinence, and 10% had difficulties in intermittent self-catheterization. 5% required an indwelling catheter during pregnancy. The median delivery was 36 weeks, but almost a third of patients were born before 37 weeks, and 3.5% were born prematurely between 28 and 32 weeks. 60% were delivered via C-section, and there were 20 interpartum complications, 12 of which were urological in nature, and 3 reconstructions had to be abandoned due to the significance of the injury. In terms of postpartum urinary incontinence, 5 women reported de novo or more severe urinary incontinence at 6 months, and 8 women required secondary anti-incontinence surgery. 4 women required surgery to treat a vaginal prolapse. 3 of these had an elective C-section, and 1 had had a vaginal delivery. So in conclusion, prenatal closure of neural tube defects can reduce the sequelae of spina bifida. The goals of care postnatally are to protect the kidneys, to achieve bladder and bowel continence, and to explore sexuality and independence. Transitional care reduces unscheduled care, and perioperatively these are high-risk patients, and creative positioning solutions may be required. These patients have the same desires as able-bodied people, and they may need help to reach their goals. So I'd like to thank Dr. McNeely for his assistance in creating this presentation, and I'll now invite any questions.